Welcome everybody to this part of our trauma symposium and coming on the EMS track. We're really excited that all of you are here. I just wanted to make an announcement for EMS providers. You guys might have seen this at the front desk. So this is going to have all of your CE codes here, and for you to get credit, a lot of you might be familiar with CE Connect. You have to have a little account, but there's some directions on the back. But you do need both of these. You need the QR code and you need this code right here on this side in order to get your CE credits. So when you scan this, it's going to ask for this code when you enter in that. So just wanted to make sure that you know about that. So otherwise, thank you for being here. We're so excited for this lecture, and I'm going to go ahead and let Laura Harwood introduce our lecturer.
All right, thank you all for being here. This is Dr. Ansari. He's one of our neurosurgeons, and I'll let him tell you a little bit more about his background and everything. But I really want you guys to take a lot away from this, so please feel free to ask questions and kind of see what things stand out. And the other piece that I wanted to mention, if you haven't signed up and if you're interested, the Fly for Life simulation trailer still has some spots. So there's plenty of spots, especially this afternoon. So take a look at that if you haven't already signed up. Should be really fun. It's not like we're not like trying to trip you up or anything. So it's good to go like run a scenario with the simulation. I'm the simulation coordinator on this side. So anyway, thank you guys for being here. And Dr. Ansari, thank you for being here. And I'll let you take it away.
Thank you, Laura. Good morning, everyone. Thank you for inviting me to speak at this event. And I'm, as Laura said, Sherry Ansari, neurosurgeon at St. Anthony Hospital. So my sort of specialty area is brain tumors and skull-based surgery. But as neurosurgeons, a lot of what we do revolves around taking care of patients with traumatic brain injury in the hospital and afterwards. So today, sort of for the formal objectives of this talk, we want to look at some historical trends in traumatic brain injury, where things have been, where things are now, and then specifically for you all as pre-hospital providers, be able to look at identifying, be able to intervene on some traumatic brain injury factors that can actually improve outcomes. So over the last 100 years or so, we've definitely improved our care of traumatic brain injury from back in the day when we didn't have ventilators and technology that allowed us to actually properly care for these patients, and the best they could do was lie them on their side. You'll see a lot of images of head CTs on this, and if you guys are ever at St. Anthony's and you see one of us and we're looking at images in the ER, feel free to just pop over and say, hey, what are you looking at? Can you show us through? On the top left here, you're seeing an epidural hematoma. You know it's epidural because of the shape of the hematoma. It looks like kind of this lens shape, we call it. And the reason for that shape is because it's displacing the dura, which is normally very tightly attached to the inner surface of the skull. And it actually, it's because it's tethered on either side by your sutures on your skull, it only has the ability to fill that sort of potential space. Contrast to a subdural hematoma, which is that second picture where it's sort of much more diffuse over the whole surface of the brain. That patient has bilateral subdural hematomas on both sides. And then a contusion, which is that third picture where the blood is actually inside of the brain. So this is an injury that happens within the brain itself as opposed to outside. And then the bottom image here is the penetrating trauma. So you can see the trajectory of the projectile actually crossing the midline there. That's usually not a good thing. So this is a little older trend data, but basically we see about 150,000 deaths from traumatic brain injury every year, 100,000 patients that require us to operate on them nationally. And there's anywhere from probably on the higher end of this now, 2 million to 6.5 million survivors of TBI in the US. And they can be all manner of severity, whether they're functional people that are out in society working and living their lives, to people who are much more severely impaired and really requiring round-the-clock care. Overall, though, the incidence and the morbidity and the mortality from these things are going down, which is good. That means that all the things we're doing, messaging on public health, seatbelts, helmets, all that stuff is making a difference in terms of reducing the injuries from happening in the first place. So the best way to treat TBI is to not have one in the first place, because once you've had it, then your options are much more limited. So again, just that sort of pyramid where we see the number of ER visits, the number of hospitalizations, the number of deaths, and over a million, probably closer to 2 million now TBIs each year in the United States. Because younger people, they're out there doing stupid stuff, they're more likely to get TBIs. And then people who are older, because their balance is not as good, or they may not have a very safe environment, they're more likely. But in the sort of middle there, you have that dip where people in their 20s, 30s, 40s, 50s tend to have less visits for TBI. So again, why are we seeing these? Improved messaging and improved care. So better paramedical services, trauma centers, and then the messaging on around prevention, seatbelts, airbags, drunk driving education, all that stuff that happened in the 90s that improved to better outcomes. And then, of course, the actual care once they're in the hospital, better technology, better monitoring allows us to have better outcomes from the patients that do end up in the hospital. Some studies from the 90s that just showed in terms of where we're headed, death trending down, which is good, good recovery trending up, which is good. That's what we want to see. So what are the sort of predictors or indicators? How can we try to predict when somebody comes in, what is their outcome likely to be, or how good is their outcome likely to be? So older patients tend to do less well. That sort of makes sense. Their brains don't have the same potential to recover as younger people do. Lower GCS, we'll talk about GCS later. You guys are probably already familiar with Glasgow Coma Scale, but we'll talk about it a little bit more later. People that have abnormal motor, abnormal pupil responses, those feed into the GCS. So if you come in looking worse, kind of rule of thumb, if you come in looking worse, you leave looking worse. If you come in looking better, you leave looking better. And then some of the actual parameters that we can potentially intervene on. So hypotension, low blood pressure, people that have lost a lot of blood, have no vascular tone, they're not perfusing their brain as well, they're more likely to have poor outcomes because of secondary injury. Same thing with hypoxia. If they're not well oxygenated, then they're more likely to have worse outcomes from their TBI and also other organ injuries potentially. Then people with sustained intracranial pressures or ICPs above 20 millimeters of mercury. We'll talk a little bit about that a little bit later as well. So really what we want to prevent is secondary injury, because we know secondary injury increases mortality, increases morbidity, worsens outcomes. So if we can, once the patient's injured, if we can get to them and get them to a place where we can optimize some of those parameters, blood pressure, oxygenation, and so forth, then we can decrease mortality. We can decrease morbidity. What about the CT scans? So the CT scan is not the end all be all, but it is important in sort of helping us understand the severity of injury at the outset and then predict some of the potential outcomes. So do they have a hematoma? Do they have a lot of swelling? So this image on the bottom right has what we call compressed cisterns, and you can see there's not a whole lot of space in there. There should be some space in there where there's spinal fluid normally. And because the brain is so swollen from a diffuse injury, that space has disappeared. Midline shift, you see that on the left image here with these subdurals where the brain is shifted over. Again, predictors of poor outcome, predictors of really markers of severity of injury. And then subarachnoid hemorrhage, meaning blood in the spinal fluid spaces around the brain that can indicate injury to blood vessels and axonal injury. So over the years, these guidelines have developed and have been revised several times. And nowadays, the fourth edition, that was, I think it was 2021, is the most recent iteration of these and the most up to date in terms of the current evidence and sort of the forms the framework for us to follow of managing these patients in the hospital. So when we monitor intracranial pressure, so somebody that comes in with a poor GCS, less than 8, often they're intubated, they have an abnormal head CT, it's recommended to place an ICP monitor. So you may see us do this in the ER. We often do it in the ICU. It's just a little catheter, and I have a picture of it coming up here. The idea being if we can monitor the pressure in the brain, the swelling, as a marker of the swelling in the brain, and treat that swelling, we can potentially improve outcomes. And what we know is that people that have, and this is a funny way they word these because of the nature of the evidence, somebody has elevated ICP for a prolonged period of time, they're more likely to have a worse outcome. What does that mean? Well, means if you theoretically, if you treat ICP and bring it down, you can potentially improve their outcome, but the data doesn't technically say that. The guidelines can't say that. It's just the funny thing of how these are worded. The secondary thing to ICP is what we call CPP, or cerebral perfusion pressure. So basically blood pressure minus ICP, how much actual blood is getting into the brain. If the ICP exceeds a certain threshold, that CPP will start to diminish, and then you start to get secondary injury, hypoxic injury to the brain, and can develop actual strokes. Again, the level of evidence and this sort of stringency with which they form these guidelines, they can say that you should look at CPP and it can improve mortality, but they're not going to say chase a specific parameter. So then based on this information, we develop parameters to say, okay, we want a CPP of 50 or 60, and then decide how much we're going to push specific parameters or treat other things to try to achieve that goal. So are we going to try to push their blood pressure? Well, what implications might that have for other injuries that they have? If they've got a pulmonary contusion, or if they've got other contusions in their brain, kidney injuries, things that, so it's sort of balancing all these factors of patients who have systemic, multi-systemic injuries to try to figure out how to best optimize each parameter. So how do we control ICP or CPP? Well, we can drain spinal fluids. We can place what's called a ventriculostomy, and that's one of these devices, basically a catheter that goes into the ventricle, allows us to drain spinal fluid out, goes to a bag at the bedside, and actually reduce intracranial pressure by reducing what's in the head. Think of the head as a rigid box. You have, in normal circumstances, three components to that box. You have brain, you have spinal fluid, and you have blood. So if any of those increases, then you're going to have a problem because the box size isn't going to increase. So you can address pathology by reducing the size or the contribution of any of those components. So if the brain is getting swollen, you can do things to treat that. You can treat with osmotic, for example, mannitol, an osmotic agent, which sort of dries the brain out, pulls water out of the brain. Hypertonic saline and 3% saline does the same thing. You can also hyperventilate the person. Hyperventilation reduces blood flow to the brain, so it reduces that blood component. That is limited with how effective it is and how long it can be effective, and we'll get to that a little bit later because that's one of the interventions that you all can undertake in the field in certain circumstances. Sedation similarly reduces blood flow to the brain, can also reduce the volume of the brain a little bit, and then neuromuscular blockade. We can paralyze people in extreme circumstances where they're having difficulty controlling their intracranial pressure. That paralysis reduces the effect of the Valsalva when they're fighting the ventilator and raising ICP that way. You can treat blood pressure to an extent. If someone's very hypertensive, lowering their blood pressure can also help with reducing ICP. And then when we're talking about things like barbiturates or really advanced therapies for ICP, we're also talking about surgery typically. And so often those are patients who are pretty ill, pretty severely injured, and oftentimes the conversation also involves sort of not doing those things and backing off our interventions. This is what that CSF drainage looks like. So it just drains into a bag. This allows us both to monitor pressure, but also to drain spinal fluid. So allows us to reduce intracranial pressure at the same time. The parenchymal monitor, basically a little catheter that sits inside the brain substance itself, and that can monitor the pressure within the brain, is also a very useful tool because it gives you continuous number basically that you can follow. So hyperventilation is useful in that by reducing the PCO2, you basically vasoconstrict the cerebral vasculature, and that does reduce ICP, but it stops working after 15 or 20 minutes. So it gives you this window of time. Oftentimes when we're getting somebody ready to go to the OR, we use that as an adjunct to just buy us a little bit of time to get the OR ready. Again, it can buy you some time to get them to the hospital safely. It's not something that we can use long term. Also, because it has other effects down the line with other systems. So cerebral oxygen tension is a controversial thing. About 20 years ago, they were placing central lines to get jugular bulb monitoring. So in the jugular vein, monitoring the arteriovenous difference of O2, basically how much oxygen is the brain taking up. And it might reduce mortality, might improve outcomes, but the reality is we can place these monitors. We actually have a monitor that allows us to both monitor intracranial pressure and the oxygenation of the brain. But what we don't know is how much of a difference it makes. So this is the old school machine from 20 years ago. You see it's very involved. I'll show you the new catheter here in a minute that allows us to, actually it looks like this. It just hooks up to a box at the bedside and it gives us a number. Problem is we don't really understand what to do with that number. So we don't have great data to back it up. We know that optimizing oxygenation improves outcomes, which is kind of obvious, but we don't really have the data to support this sort of minute by minute monitoring of cerebral oxygenation. What difference does that make? That's just the insertion of the jugular catheter. Again, it's a very antiquated procedure that's not really done anymore. what about making them cold? We make people cold for a lot of things, make them cold for heart attacks, sometimes we make them cold for strokes. What we know about traumatic brain injury is that hypothermia doesn't really help them. So in fact, keeping them at euthermic temperatures or trying to warm them is often better for their overall outcome than trying to make them cold. Similarly, one of the few level 1 evidence-based guidelines in the entire set of guidelines, which is a 240-page document, is that steroids are not indicated. So in patients with TBI, there's no role for steroids. There's no improved outcome with steroids, and it's actually contraindicated because they increase mortality, mostly related to secondary things. So more likely to get infection, more likely to get complications of steroids, wound issues, so forth. Hyperosmolar therapy is really kind of our mainstay of how we treat ICP medically. So this is mannitol, it's 3% sodium chloride. And I don't think we're at the point right now where 3% of sodium chloride is available in ambulances. But it's one of those things that they're currently discussing and doing research on. Is this an early intervention that might actually improve outcomes? So is this something we can start putting in the pre-hospital setting in patients that potentially have elevated ICP in the field? Can it be given to start reducing ICP as the patient's on the way? The data is not out right now. It's being sort of worked on. But we know that we can reduce ICP by treating with hyperosmolar agents. We know that treating ICP improves outcomes at 6 weeks and 3 months and 6 months after injury. So therefore, we recommend treating with hyperosmolar agents to reduce ICP. Ventilation. So we know that prolonged hyperventilation is not recommended. Again, short-term hyperventilation as a temporizing measure can be useful. In that first 24 hours, when blood flow and perfusion and the sensitivity to secondary injury is very high, it's recommended to try to avoid it. Again, if you're temporizing, it's okay, but it's not something that you want to use for longer-term management. So what about surgery? That's the stuff that gets me excited because that's what I do. So different types of hematomas have different types of management. This what we call an epidural hematoma. Again, the lens shaped. If it's greater than 30 cc's in volume, or if they have a decreasing mental status or a focal neurologic deficit, they go to the OR. Oftentimes, these are associated with skull fractures. It's not projecting very well, but that patient does have a skull fracture because it also avulses an artery that runs along the dura inside, and that causes the epidural hematoma. Subdural, similarly, if it's 10 millimeters or greater, if they've got midline shift, we're usually going to evacuate those. And then intracranial hemorrhages or hemorrhages within the brain are a little more controversial. These oftentimes will develop in a delayed fashion. So somebody may come in with a little bit of blood in their head. Over the next 24, 48 hours, they develop more blood in their head. Sometimes we see a corresponding increase in their ICP that becomes harder to control with that sort of mass lesion. And so then we end up having to decide, do we go to the OR, do we not? Sometimes people develop these contusions without increasing their ICPs, and we just watch them. Sometimes they develop ICP elevation as the contusions blossom, and then we go in and actually, at the very least, decompress, if not evacuate. Back in the day, they used to recommend a bifrontal, meaning throw an incision across the top of the head, peel the scalp down, and take off the front of the skull. Not ideal for a couple of reasons. One, it doesn't really improve outcomes. Two, it's cosmetically very difficult for people in the recovery phase and then having to get a cranioplasty. So nowadays we do what we call unilateral frontotemporal parietal. So a big incision along the side, take off half of the skull on the side where the pathology is. So in this patient, for example, this would be on the right side, allowing the brain to swell out and then placing that flat back when the swelling is resolved. Cosmetically better, associated with better outcomes than that bifrontal. So when do we operate? We operate when patients are becoming worse if they're not responding well to the medical therapies. They're not responding well to the osmotics. We can't control them with sedation. If they have an EVD, we can't control them with EVD. And then trying to maintain these other parameters. So you want to maintain MAP above 90 with fluid resuscitation to perfuse their brain, but also all their other organs. Because oftentimes, these are not happening in isolation. So there's other injuries as well. They may be losing blood from a vascular injury. They may be losing blood from a hip fracture, something intra-abdominal. And so it all has to be done in the context of whatever's happening overall with the patient. And with these guidelines and compliance with these guidelines, things are actually getting better in terms of outcomes. So we see implementation over the 1990s, overall improving, less hyperventilation being used, steroids basically disappearing, ICP monitoring improving or increasing, and then trying to treat these patients at the level 1 trauma centers, which is typically the recommendation. This is just that calculation for CPP, so you can do this pretty quick and dirty if you just see the patient's monitors, their map minus the ICP. ICP ideally should be under 20. That's 20 is sort of the threshold where we start getting worried and start treating it. Goals of therapy, goals in managing these patients. So we want to correct any derangements, hypotension, hypoxia, resuscitate them appropriately, maintain that CPP. Again, it's that balance of blood pressure and ICP. Maintain the ICP less than 20. Get CT scans if you need to. We're never shy about getting repeat CT scans in the hospital. So if somebody was looking okay and they're not looking okay, they get a CT scan. If somebody develops a new deficit, they get a CT scan. If somebody's ICP is running persistently high, they get a CT scan. So you can sneeze the wrong way in the ICU and you'll get a CT scan. Avoiding hyperthermia, but also hypothermia. So we know both of those can worsen outcomes. And then early nutrition. So this is a more recent development, but if somebody's sitting in the ICU for 72 or more hours and they're not getting any nutrition, that is associated with worsening outcomes. So placement of enteral access, getting the nutrition early is going to be better for their long-term outcome. We do see in some patients that develop progressive hemorrhage. So these patients, initial CT scan on the top frames there and the later CT scan a few hours later on the bottom. This is the reason for repeat CT scans. And generally speaking, we tailor that based on what they look like initially. So if somebody comes in with a pretty trivial small amount of blood, they might get a CT scan the next morning at the very most 6 hours later. If somebody comes in with a really nasty looking CT scan early, we might scan them earlier, 2 hours, 4 hours, and also if they're on blood thinners. So really important for us to know when they arrive, are they taking something like Eliquis or apixaban? If they are, we want to scan them earlier because we know they have a higher risk. Do we need to reverse them? All those things play into the decision-making at that point. Injuries or secondary injuries after, this is just kind of reiterating that patients that have initial intraparenchymal hemorrhage tend to have a higher rate of developing a greater hemorrhage later on. Patients with epidurals less so, and then the subarachnoids and subdurals, they tend to have less sort of secondary bleeding later on or evolution of these hematomas. We call it blossoming in some cases. So what do we do when somebody is sort of acutely declining, intubated if they're not intubated, hyperventilation to just buy us some time, make sure their volume resuscitated, make sure their blood pressure is okay. Elevating the head of the bed can be a very helpful move, and by itself in some cases can bring the ICP down. Just getting venous drainage, straightening their neck, making sure they're not kinked over, making sure if they have a cervical collar it's not too tight. All those things loosen pressure on the jugular veins, allow venous drainage, and can increase or can reduce ICP. Sedation can be very helpful, and then bolusing hypertonic saline or mannitol. The other thing that is important to think about are seizures. So oftentimes patients with TBIs can have seizures either at the scene or later on during the course. If they're having a seizure, even if it's subclinical, that can be a reason to have elevated ICP and difficult to control ICP. So one of the things we'll often check in somebody who's becoming difficult to control is, are they in status epilepticus and do we need to treat that? Not everybody necessarily needs to get prophylactic anti-seizure medicine when they come in. Often we'd give it for patients that have hemorrhages of some kind, but patients that don't have hemorrhages but have TBI that's not as evident on imaging could still have seizures and could still have elevated ICP as a result of that. Evacuating mass lesions, obviously taking patients to the OR to take out things that are pushing on the brain. So fundamentally, what we do in neurosurgery is we make space. So if you're running out of space, we make space, whether it's in the brain or the spine. Can kind of boil it down to that one way or the other. So we open the skull, we remove the subdural. One of the controversies that remains is how much do you hyperventilate? How long do you hyperventilate? Defining that optimal number for CPP or cerebral perfusion pressure between 50 and 60 is kind of the accepted number right now. But again, how much do you push somebody's blood pressure to try to maintain that CPP? And then when to use decompressive craniectomy. So this was a conversation that was ongoing for a long time. Does it make more sense to take somebody to the OR early right away when they come in if they're looking like they might have elevated ICP, or do you wait, try to treat them medically for a little while, and then take them only when they become refractory? So the question was sort of answered probably as definitively as it's going to get by this trial called Rescue ICP that was published in 2016. And this was basically randomizing people into two groups, whether they get early surgery for refractory ICP or they get more medical control and not get surgery at all. What they found is that we save a lot of lives doing this, but we also create a lot of disabled people. So that's become sort of a values conversation with families where we have to have a very frank conversation with them and say, we can probably preserve their life, but what is that life going to look like afterwards? And a lot of times families don't, depending on their level of medical literacy, may or may not have a good understanding of what that actually means when somebody is severely disabled, vegetative state, and not able to care for themselves and maybe requiring long-term care. So one of the nuances and can be a very complicated conversation at some time. Again, preventing secondary injury, very, very important. So that's the whole goal of everything that we do. CPP targeted, ICP targeted, depending on what you're allowed to do based on the patient's other injuries and other comorbidities. And it doesn't seem to make a difference whether you treat CPP or ICP. The idea being you have a number of parameters, you try to optimize each one, do the best you can, and oftentimes you have limitations. So as far as pre-hospital things are concerned, so there's actually a set of guidelines for this as well. That document's a lot shorter, thankfully. But the idea is if you have a patient with a suspected TBI, they should be monitored for hypoxia, oxygen saturation less than 90, hypotension, systolic less than 100, hypertension, systolic less than 150. So that gives you a sort of window to look at keeping them within that. Hyperventilation and hypo or hyperthermia, they should be continuously monitored for blood oxygen saturation. So pretty much as soon as you get to them, if you get them, the ambulances typically have pulse oximetry, right? So you get them on pulse oximetry, continuous monitoring throughout until they get to the hospital. Probably the number one thing that you guys can do, and then resuscitation, full resuscitation out at the scene and on the way with crystalloid to prevent hypotension. Glasgow Coma Scale. So this is probably familiar to you guys, but this is a very reproducible, very easy to communicate number that you can give. And if you walk in and say somebody's a GCS of 7 or somebody's a GCS of 14, I know exactly what they look like. And that one number communicates more to me than a lot of things that anybody can say otherwise. The other thing about GCS is it tracks with outcomes. So somebody that comes in a GCS of 4, we know that their outcome is not going to be great. Somebody comes in a GCS of 13, they're probably going to do okay. And so if you're not familiar with the GCS, it's a very logical sort of stepwise going downward. If you go from the top down. So if somebody is sitting in this room, maybe their eyes are closed after I've been talking, I don't know, but if their eyes are open spontaneously, then they get 4 points on the eye-opening scale. If it takes a little bit of, hey, sir, how you doing? Or hey, ma'am, how you doing? Then that gives them a 3. If you have to really pinch them or sternal rub them, that gives them a 2. And if they don't open their eyes at all, that gives them a 1. So you get a GCS of 3 just for showing up, just for being there, but you could be dead. Verbal response, if they're awake, oriented, they're talking to you and sound appropriate, they get a 5. If they're sort of confused, babbling, not really making sense, then they get a 4. If they are just making sort of sounds and very agitated or very confused, that gives them a 3. And if they're just moaning, that gives them a 2. If they're not verbal at all, or if they're intubated, they get a 1. So intubated patients automatically get a 1 on the verbal response. And then motor response is probably the most important because it tracks the most with long-term outcomes. So if they're awake, they can follow a command, they can raise their hands up, they can move their feet, they can smile for you, they get a 6. If they localize to pain, they get a 5. And localized truly means crossing over the midline. So if you pinch their right shoulder or left shoulder, they have to cross midline to try to get you. If they get like this, it doesn't really count. So that's more of a withdrawal. Withdrawal meaning you pinch them, they actually flinch back. That can sometimes be confounded in the legs with what's called a triple flexion response, and that's an abnormal response in the setting of spinal cord injury. So again, you want to look at all the extremities when you're examining somebody in the field. And again, going down if they're posturing. So if they flex when you stimulate them, they get a 3. If they extend when you stimulate them, they get a 2. Those two things are related to which level of the brainstem is actually functioning. So somebody who's comatose may only have brainstem function. Which level of the brainstem is functioning gives you flexion or extension posturing. And then again, if they do nothing, they're a 1. So you put those together, you add them up, and you get a number that you can give. And you're going to give that number to your dispatch. You're going to give that number to the ER, the trauma team, to us when we arrive. And so that number is going to determine the intensity of intervention that patient's going to get in the subsequent minutes. Most importantly, post-resuscitation. So if somebody's in the field, they've lost 2 liters of blood, their GCS is not valid. You resuscitate them, you get them tanked up, then you do a GCS, and that is your true GCS. So sometimes they come in and they're not fully resuscitated, so we want to resuscitate them in the trauma bay and then get a GCS, and that gives us a much more accurate verification. The other thing that you can do is you can look at the pupils. So again, after resuscitation, after stabilization, are they symmetric? First of all, is there sort of any ocular or orbital trauma? Because that obviously invalidates your pupillary exam. But is it asymmetry? Are they responsive to light? If there's unilateral or bilateral fixed and dilated pupils, that's a very, very bad thing, very bad sign typically for their level of function in their brain and their outcome, ultimately. Interventions that you can do. Number 1, oxygenation. Establish the airway, give them oxygen, increase their oxygen saturation, increase their cerebral oxygenation. Fluid resuscitation, make sure they've got good perfusion to their brain, and isotonic fluid and blood products depending on what they need. And then touching again on that idea of increased ICP, are you looking at a patient that might have increased ICP, and what can you do to address that? So in the field, potentially mild hyperventilation. Maybe in the future they'll start putting hypertonic saline in ambulances, and you have that as a tool in your tool belt, so to speak, to start treating patients as they're on their way. What are some indicators of increased ICP? So what's called Cushing's triad is a sort of classic triad of hypertension, bradycardia, irregular respiration. Obviously, it doesn't count if they're already intubated, but if you see this in somebody, their blood pressure is touching 180, 190 systolic, their heart rate's dropping into the 30s, that's an alarm sign. That means that they may have increased ICP, and we want to get moving on those patients pretty fast. GCS less than 9 upon arrival, potential for severe traumatic brain injury, increased ICP. If they're posturing or they've got some kind of lateralizing findings, so if they're not moving one side, if they're posturing on one side but not on the other, or if they've got an asymmetric exam where they're withdrawing on one side and localizing on the other side, or following commands on one side and not moving the other side. Obviously, you're always thinking about stroke too, but in the setting of a trauma, you're thinking about a mass lesion in the head. And then the fixed and dilated pupils. Bilateral, typically that patient may not make it. They're probably not going to make it. Unilateral, we may have a window of time where we can actually do something to help them. You want to avoid, if you can avoid hyperventilation, you want to avoid hyperventilation. But if you've got somebody that looks like they're starting to herniate, they've got that Cushing's triad, they've got an asymmetric pupil, hyperventilation is a tool that you can use. So if it looks like I'm contraindicating myself, I'm just trying to say that if you can avoid hyperventilation, avoid it, but it's a tool that you can use. And then you want to avoid giving these people TXA initially until we have a really idea of what's going on with them. This is the graph that I wanted to show you guys. So you can actually decrease ICP if you hyperventilate somebody. So the blue line here is the CO2. So if you drop the CO2, the ICP comes down as well for a while, and then it stops working as well, and then ICP starts to creep back up. So to maximize patients' outcome in the setting of severe traumatic brain injury, you want to get to a trauma center fast. So you might be in the mountains, you might be remote somewhere far away, but you want to get them to a center capable of taking care of TBI patients as quickly as possible. You want to aggressively treat the things that you can easily correct, the hypotension, the hypoxia, so resuscitation, oxygenation. And then once they get to us, if there's anything that we can intervene on emergently, we want to evacuate mass lesions. So if there's a subdural, if there's an epidural hematoma, we want to get that out. And then we want to maintain ICP below 20, CPP 50 to 60, or a little higher. And again, within the range of what we can do. Avoid ischemia globally, but try to maintain the O2 saturation that allows you to titrate other things if you need to. And people tend to do pretty well, despite sometimes looking pretty bad when they come in. We've had patients that come in looking not great, But if we can maximize all these things, they can actually have a pretty good outcome. And after the course of rehab, end up going back and living their lives. So the brain is more resilient sometimes than we give it credit for. So that's the end of my slides. But what questions can I answer for you guys?
With you mentioned PaCO2, and then you have the diagram with the end tidal. What's our target end tidal CO2 ideally?
Ideally normal, so 35 to 40, unless you know something's up. So if you've got one of those alarm signs, then you can start targeting something more like 28 to 30, roughly. Mild hyperventilation, you don't want to go nuts, but mild hyperventilation to just buy yourself some time.
What breaths per minute would you suggest to start with for hyperventilating?
18 to 20. I'm not an intensivist by any means, but I've played with ventilators once in a while. And if you have the ability to do that, if that's the situation you find yourselves in, that's a good place to start.
So with the like hyperventilation, say it's like a 15-20 minutes, kind of like your stopgap essentially. We'll have long transport times like an hour and a half, if we won't have that ability to like get man fall or anything like that. If we do like hyperventilate for that whole, hour and a half, does that impact long-term like prognosis and outcomes as well as much? Or is it you need to do what you need to do to get them there type thing?
I think in a circumstance like that, you got to do what you got to do to get them to us. What you'll probably find, if you do hyperventilate them the whole hour, you're not going to probably harm them, but the effect of the ICP lowering will probably taper off after about 15 to 20 minutes. So it won't be as effective after that time. Now, if you're in a transfer situation where they're coming from, Summit and they're coming down here, or they're coming from Durango, and we know there's going to be a prolonged transit time, and we've looked at the CT scan, we often will say, give the patient a bolus of mannitol or a bolus of 3% before they go, so that we can start getting some control. And then meanwhile, we can prep the OR for their arrival. Sorry, in the back and then you.
You mentioned the potential use of hospital hypermolar therapy. So I know that it's not available, but if they were available, how will you handle that? And what will be the infusion? Will it be polytrauma, a contraindication?
That's a very good question. So that's where there's not data backing that idea right now. There are studies being done on that idea, and you have to do it within the context of what their other injuries are. So I think when guidelines come along for that, it'll probably come with bolus guidelines, infusion guidelines. Typically, we treat it as a bolus because that's when it's most effective. So we might give a bolus of 250 cc's of 3%. And if we develop the ability to do that in the pre-hospital setting, I think that could be a real positive outcome or positive improvement for the care of these patients. Good.
So we continue to have this difficulty because depending on which one of the neurosurgeons we talk to, you guys all kind of have maybe a little varying opinion on what this should be, but I know we want to avoid hypotension and obviously a blood pressure less than 100 when we don't know what their ICP is, but we do have lateralizing changes, GCS, 8 or 7 or whatever. And we may be giving 3%, like but we can't measure their ICP, right? So we can't really know what their CPP is. So what would you, in your opinion, say should be the perfect or the optimal systolic blood pressure to try to maintain them in? Like, do we use 120? Do we use, because don't want to be less than 100. Well, what if they're like 108,
Yeah.
And you kind of go, well, if their ICP is 25 or 30.
Yeah.
Now their CPP is down in the.
That's a very good question. And if you ask 10 neurosurgeons, you might get 10 or 11 different answers. But I think the idea is to try to optimize what you can. So if the goal is systolic blood pressure greater than 100 or quote unquote normal retention, and the patient's got 108, but they look like they might have high ICP, that might be the best we can do for that moment. And so then our goal would be, as soon as they get to us, to get a monitor and so that we can monitor that ICP, or if we know there's a mass lesion, to get them to the OR and evacuate it. If it's somebody that's looking really sick and potentially like they're going to need to go to the OR, then we'll already be getting ready on our end to do that. But a lot of times you're working with incomplete data in these situations, especially when they're in the field, but even when they're in an outside ER somewhere. And so you don't have all the information you'd want. So if you know that you're in the ICU, it's a very different situation. They're very controlled. You have all the information, you have all your parameters. But when you're in a transfer situation or in an outside facility, you have to do your best with the information that you have. So I'm almost never going to recommend somebody to push a normal looking blood pressure higher without having knowledge of what their ICP is. If you tell me the patient's blood pressure is 108 systolic and they've been stable on that and their exam is stable and not worsening, then I'll say that's okay and just get them down here so we can get a monitoring. But that's a complex situation. Yeah, as these often are.
And for whoever asked that there in flights, we are able to give hypertonic saline. We use if they have a lateralizing sign, so one pupil or both pupils fixed and dilated, if they are posturing, all those signs that you talked about of increased ICP, those are the parameters we use for when our crew can go ahead and just give it. And we use a bolus of 150 cc's and they can repeat it if they don't like it better. So that is, if, you know, trying to prevent somebody from herniating during longer transports coming, coming a long ways from Durango or bad head injury in Summit or whatever. So, and what we've kind of been told is that the hypertonic saline, that it doesn't really have significant bad side effects for us to be going ahead and giving it to a patient when we don't have an ICP.
It's a pretty benign intervention. You know, if you're going to give somebody 1 or 2 boluses of hypertonic saline, you're not going to torch their kidneys. You're not going to do anything really bad to any other systems. And you treat their ICP a little bit. And again, you can repeat that once or twice if you need to. I mean, we'll repeat and drive people's sodiums up to 160 in the ICU. Again, when you have data to work with, it's much easier. But when you're working with limited information, again, you have to make the best decision that you can. So that's why I think pre-hospital hypertonics is it'll happen eventually. It's just a matter of getting the data in place to support it.
So I have a question. So, our Grand County partners here, they do have long transport times.